Larry's here. But you'd rather know than. We need to have one of the kids take cans back. Yeah. I mean, probably Vaughn, because I'm sure Connor's never done that in his life.
Yeah. The nice thing about having Connor do it though is it gives all the veteran unleashed people something to complain about. With one of those Ohio people taking cans back again. Sometimes they just bag them up and put them out back and see how long they stay there, which is never very long.
I'm sure there's a couple bums that go by. There used to be a guy in Ida that's all he did. He'd go dumpster diving for cans, and then he's like, "Yeah, I'm retired, so I just decided to supplement my income." That's sad, dude.
Just such a pain going through the actual returning them.
I'll do my own, but like a bag or two. I don't do more than that, and I use it to buy more cans. So,
Well, then you get the machine's down. Well, the state law says you have to take these back. It doesn't say you have to take them back as long as your machine's working. So get somebody over here and take care of this. I can't remember the last time I actually took cans back myself because I just get so pissed off about how they do it.
once you get to that point where it's like,
Well, we don't have to. Yes, you do. It's actually in the freaking law.
when we get to the like machines down part, I usually just go to the next person. I'm like, "Hey, do you want these?"
Yeah.
I'm not waiting for this.
Great.
Oh no, Larry. Are you okay?
Yes.
Hey Eric, how you doing?
We're good, Dave. What is going on?
Too much. Not too much. Just run around like a chicken. Dead.
About right.
The presentations from Jim this week were just degeneration and some essential illness scripts. I think we also covered a little bit of instability. I was going to go over just some of the notes I put up there, just on concepts underlining instability, and we can kind of generally loosely cover on how these relate to different illness scripts and what we may see. Try and tie it all together. What you'll find is these presentations aren't going to be a re-summary of the Zoom presentations. We'll cover the video presentations. We'll cover some of them, but there's no sense in reiterating it. You know, Jim does a really good job of explaining it. Sometimes you may have to watch it more than once. My recommendation is take notes on it if you can. But we expect you guys to kind of view those presentations, these Zoom sessions, also come with the notes. So, but again, we're always happy to ask questions. There is the discussion board. You can email us directly. You have any questions about stuff in the presentations or anything else, don't just kick around in the dark. You know, please feel free to contact us. We're more than happy to kind of clear up small things or big things or anything in between. Let me see if I can share my screen. If you run over time out of this, then we finish up with this topic, then we can get into some of the disc concepts on disc herniation as well. Jim covered that a bit, but it's a nice one to do because it's just a different model in the way we think about discs and disc lesions. So several different models to kind of think about, and we can kind of go over some other ones of just, what is spinal instability? If I were to talk about spinal instability with a spine surgeon, what goes through his mind is completely different than generally what goes through the PT's mind and what they call instability and what they think of instability. They're thinking of something probably on that functional instability with Kirkcaldy and Lewis scale where they're thinking surgical. Is this something that needs to surgically be fixed in instability? Where we're often thinking functional, mechanical, or clinical, like Punjabi or in the world of Cook, as far as an instability. And Punjabi's kind of the classic reference, right? I mean, Eric, you'd agree. That's kind of the one that you've heard about all the years. You've been PTs and the model. It's been expanded on a good bit since then.
Yeah, I mean, Punjabi, Bogduct, and Twami, all of these guys have kind of used similar types of descriptions for these things. I think Punjabi's probably the first one that, really made it mainstream.
Yeah. And, it's a concept of, you have the collaboration of multiple systems. There's usually like a three-circle model that they'll use where you have the passive system, which is about vertebrae, intervertebral discs, ligaments, facet joints are going to be in that model. You have the muscular system that's going to control it to our muscle control, and then the neural control in the subsystem. Where does the neural system come in as far as timing, force output, optimal angles even could probably be considered in there as well. We'll elaborate on it a little bit in functional model, and Kirkcaldy and Willis is a good one to kind of be familiar with because it's a three-stage model of degeneration. And to kind of shortly summarize it, it's that, the first stage is this mild instability phase, this early breakdown phase that occurs, a loss of disc height or maybe, buckling. The middle phase is the phase of instability now. Now, okay, we've lost disc height. The center of axis of rotation is usually in the posterior third of the disc. We're talking lumbar spine. It's a pivot point. We pivot around. Well, when the disc starts to break down, what happens is that instantaneous axis of rotation, that pivot point shifts all around. And instead of it being like a finite or small point or circle, it's like a scribble line. So now all of a sudden, as you go to bend forward or backward, your center of motion is pivoting all around and it creates that dynamic instability. And then, as I often joke with patients, if you get lucky enough to get old enough and your facet joints start to fuse and you get bony lips and spurring, you start to stiffen up. And that's your third phase of stability, or the third phase of this instability, where you really now are kind of ankylosing or stiffening up in that model. And Chad Cook kind of jumped on the bandwagon with some other models, and it looked a lot like Punjabi. Just talking about a condition of instability leads to clinical symptoms. He's a little bit more of a generalist. And such that back pain, it can lead to this instability, can generate nerve root irritation, detectable with clinical tests. So his model and his testing system kind of fits in there. I don't know that he rises maybe to the height of the other ones as far as referencing. First one to take a look at is kind of Punjabi's system. As we talked about, is think about the passive system as your first one. It's your vertebrae, it's your facets, it's your disc, the connective tissues, in between there, the ligaments, the disc. And the facet joint in the lumbar spine provides a great deal of stability. We'll get into that probably in about 2 weeks when we do the biomechanics a bit more. But the facet joints is significantly going to resist shear and compressive forces. Michelle, we always ask this question. What motion occurs at the lumbar spinal segment? How much flexion? Is it flexion extension? How much rotation? Told Michelle I was going to pick on her.
Very little rotation, mostly like flexion extension.
Yeah. How much rotation do you remember?
Was it like 3 or 4 degrees?
Yeah.
Total.
Yeah, total. The lumbar spine. It's not a rotary joint. And it's kind of like that 4 degree mark is also where they found that the disc starts to actually fail and break down, I believe. But
Yeah, it's also a situation where we have it's not even movement within the joint system, it's more compression of cartilage in between the two surfaces than it is actually free movement, more of that kind of quote unquote neutral zone position where there's free space for these two joints to move against each other. It's more the idea that the two surfaces are actually compressing against each other, and we start to get even bowing or bending of some of the osseous structures as well before you get to beyond 3 degrees of motion occurring. So you can tell, I mean, that the lumbar spine is not designed to rotate. It's in fact designed to resist rotation. And this plays into a lot of like passive energy generation and how the body develops some kinetic mobility and things of that sort of nature that we'll talk about going forward. It's
Yeah,
interesting
so
stuff, though.
yeah, because you
Interesting
think
stuff.
about that, it's like when we drive rotary forces into the lumbar spine, it's problematic when they get stuck there. It builds up, whether it's your golfer, your rotational sport, a soccer player, somebody playing tennis, somebody working in a grocery store who has to do repeated rotation. How the system transfer that rotation through the body. If it's getting trapped in, let's say, or conducted in the lumbar spine, it's going to generate a problem eventually.
Yep, see it all the
So
time.
yeah, and what's fun about this is that it's like going over, even did it yesterday in a lab. It's like, hey, how does my ankle influence this? How does my hip influence this? How can I take the pressure off my lumbar spine, looking throughout the kinetic chain? That's what we're gonna really this course is about. It's looking at, hey, how does my thorax, I can use my thorax better to change what's going on in my lumbar spine, treat my lumbar patient. Understanding, wow, this person's shoulder is a bit restricted and it's driving the pain again down into the lumbar spine. So it's developing over time. You have to understand it at the structural level, but program of why it's, 8 modules is that we can take it out and expand it beyond. So I can look pretty quickly and I'll look at the shoulder motion and understand why this person has back pain. Active subsystem, composed of muscles that stabilize the spine dynamically. You know, Again, this will be brand new news to everybody, of course, but your multifidi, transverse abdominis, pelvic floor, and diaphragm are your deep localizing system. Global stabilizers, rector spinae, rectus abdominis, your obliques. Big thing here to think about is, and this is where the debate comes in, like if you're over there and you're, strictly Stuart McGill camp, you're thinking one way. If you're, Hodges, Richardson, Joel, you're thinking the other way because their opinions differ. We have the different researchers where they isolated deep system activation is important, has to be done first. Where your Stuart McGill camp is more like, nah, it's more global stabilizers. I think there's enough research to support both, and that some of your patients will require a deep system strategy. Some of your patients will be fine with a more global strategy. And ideally, even after you do your deep system strategy, your next phase is going to be your global strategy in there. So there's room to pivot around there. Everyone doesn't need to start per se with TIFIDI and TA activation. It's not a bad place if you do, but it just may not be required for everybody. But
Yeah.
you're going to progress into those other patterns.
And I think sometimes especially with the research stuff, when you look at, especially Hodges and Richardson and some of that group, when they talk about the deep stabilizing systems, they talk about this anticipatory control and these muscles have to turn on before movement. And I don't necessarily disagree with their statements on that, but they say, well, it's inhibition of this particular group of muscles that allows lumbar pain to develop. Well, we can look at that from two different perspectives. We can say, well, is the loss of motor control the reason that the pain develops, or is the loss of motor control the result of pain developing? And I think you could go either way, because I think you could have somebody that doesn't have any pain at all. There's a sudden and kind of abrupt introduction of pain into their system, and then that pain inhibition, which is one of the types of reflexive mechanisms that the body has as far as motor control goes, that we'll discuss in depth, especially when we get to force output testing and things of that sort of nature. It's one of those inhibition processes that will then cause weakness in that muscle group. So the question then is like, is it best to go in and try and train those muscles, independently, which should be what we would consider involuntary muscles. These muscles, we don't have to stop and think about, okay, I need to turn on my transverse abdominis before I get out of this chair. That's not the way that the body works, right? These things should be involuntary. They should be reflexive. So it's always a question of how do we go about and do this sort of stuff. And a lot of times I think it's because we're looking at it from one particular point of view, saying that this thing was here first, and that's what allowed the pain to develop, the pain pattern to develop. But that's not always going to be the case. Sometimes the pain causes that inhibition, and we have to deal with the pain first before we can worry about the inhibition.
Yeah, that's classic. I know with classic studies, they inject saline into facet joints or the intervertebral discs of like pigs mostly, not so sometimes people, but mostly pigs. And that's where you see this immediate inhibition of multifidi in a local system. When it became chronic, it could be also on the contralateral side or levels above and below it. And then they also look at the transcranial stem that they're looking at. Then you see that the cortical patterning changes. So that feed forward mechanism then gets impaired in those cases. They see the same thing with Achilles tendinopathy, that feed forward mechanism gets impaired. And that can be some of the bigger barriers in how we're training people is to train them globally because, this is a manual therapy course. So like, why are they discussing muscles in a manual therapy course? Because when you get really good at the manual therapy, it becomes the shortest part of your treatment. And you're going to spend way more time afterward getting these other subsystems to work properly. So part of what we're here to do is to train us that the manual therapy, clinical decision, pattern recognition, those things happen pretty quick and easy for you. And then we need to have this bigger concept of, okay, how do I then get you back to build capacity?
Yeah. And I totally agree with Dave, what he's saying about, getting these core musculature muscles firing better. I look at it as like a recruitment phase. We need better recruitment out of these things and then progress to these global stabilizers, because I think the global stabilizers become much more functional for us during active movement. We start looking at things like some of the sling mechanisms that the body has, these interconnected pieces, that go across the torso, across the body in various different directions, to create these diagonal movement patterns that we have to have, because we don't operate in straight lines like this, right? We need to be able to move in different directions. There's diagonal and oblique movements that the body needs to be able to produce, whether it's for sport or whether it's for carrying things, walking, etc. All these different things, we have to be able to do that stuff. And so these global stabilizers, quote unquote, they're more dynamic muscles. They're going to create more movement, but they have to work synergistically in order to do that. All right, so we'll get more into that as we go along. It's just an interesting thought to get into your guys' head early on.
Yeah, it's good. You plant these seeds in it. You just want it to grow as we go with time. And then there's the control system that we talk about. That's going to be that neural control mechanism that's coordinating these activities. And the cortical activation is noted. It's delayed in acute and chronic back pain patients. That patterns this. And again, it's not clear. It's not like it always is multifidi on the left-hand side. The facilitation of muscles in 16 patients they looked at with back pain, they had different EMG patterns in each one of them. There are some common themes, our longissimus, ilicostalis, rectus spinae, hypertonic, maybe on longer than they should be during motions as well. Multifidi deep system delayed or underactive were the common themes in there. But sometimes in somebody, it was the right internal oblique was more active. In somebody else, it could be the left external oblique was more active. And it could be unique to their body type, their patterning, their lateral shift, their, maybe mild scoliosis. So the variations we see will be unique to those individuals. They're common themes, but there's a lot of individual variation as well. But it's good to understand the common theme first, and then from there you can branch out in the variation. And again, here we're looking at aberrant movement patterns, that choppiness to it, lack of flow in movement, lack of energy transfer that can occur. Again, here we talked about that interplay of dysfunction. Yeah, you're right. The degenerative disc, which is going to be your passive system, that can place more demand on the muscular system and how we recruit and the neural system. So that pain that gets introduced in the system will change the muscle firing pattern. And even though that pain goes away, they see that the muscle firing pattern aberrations tend to linger. So the back pain has resolved, but delayed activation of muscle pattern still remains there, or the neural patterning that's developed at the cortical level is still altered in these individuals, and that needs to be rehabbed. The same is exactly true in the neck that they find, is that, we can go in there, we can manipulate the neck, and I'm going to take away their neck pain. Okay, and they're going to be pretty good sometimes, 1-2 sessions, second session being cleanup, and they're going to be okay. But they often find that the multifidi, if they've been damaged or inhibited, may not recover. Or the sternocleidomastoid may remain upramped, inhibiting deep neck flexors. So, even when somebody gets to the no pain standpoint, it's like, okay, what amount of neuromuscular reeducation do they still need to really get back to good so they don't become a recurrent chronic neck or a recurrent chronic back is what they see. So that's always the challenge for us is because, hey, I do this treatment, I manipulate C2, they're doing they're doing great and feeling good and want to go on, but maybe that deep system hasn't completely reset. It's worth my time to go in and make sure that, okay, we can properly kind of work on a next stabilizing strategy that they can use in the gym or in life so that hopefully they build up some endurance, then also kind of, get the proper regulation of the recruitment pattern. Anything to add on that one, Eric?
Yeah, I mean, I would say the biggest biggest thing for me with that is just convincing the patient that they need that sometimes.
Yeah.
Because if you have a patient that comes in and that they, have some acute neck pain and you're like, well, it looks like it's a pretty simple facet subluxation and it's, irritated a few things. It's just like, well, we can get this going pretty quick. Assuming the safety components are where we want it to be for doing something like that. Um, Doing that's great. And then the patient's like, oh, you fixed it. This is awesome. I don't know that I need to come back. And it's just like, well, there's these other things that we should look at. But a lot of patients will want to skip that step. They'll say, well, if I need you again, I'll let you know. And, at a certain point, sometimes you kind of look at it and say, all right, well, I guess that's good for business if they have to come back and see me again. But if you can convince the patient to do those things kind of after the fact, all the stuff Dave's talking about, the re-education stuff, it's good for them, and it tends to create the more long-term solutions rather than kind of the short-term quick fixes that we get that people talk about getting all the time with like chiropractic treatments and things of that sort of nature. So that's probably the biggest issue that I have with that sort of thing in clinic is getting patients to buy into that stuff.
Mhm. Yeah, because correcting the joint and getting the mechanics down right is going to give you a rapid initial response. And then it's getting that longer term, buy-in. But ideally with this too, is you build rapport and confidence in you. And, I'll get people to come back a bit more because if I can make that big response in the first session or two and kind of really describe to them their problem and they understand the biomechanics, I get some credibility and some street credit. And then I want to leverage that street credit to see, okay, can I keep them coming in for the portion that they now need, but don't know they need? So it's you want to kind of that's one of the advantages of this, hopefully doing this too, is that as you build up that credibility that wow, you understood this right away and made an immediate impact, you start to then have confidence in you that you kind of know what you're talking about. And hey, this can come back if you don't do the proper things and work on the long-term view. Again, getting into thinking about just lumbar instability and framing that concept, like structural instability is kind of you think that medical model. You go to the orthopedic surgeon, he's thinking, okay, trauma, fractures, spondylolisthesis, conditions that are degenerative, conditions that are pathologies, what you see in the MRI. The PT world, our mind tends to think of, an instability more in that functional realm, due to muscular impairment or my tympani aren't firing and they're delayed and I need to reprogram them. So we want to kind of be aware of this so that when we're communicating, we can move between both worlds. Like if you're treating the McKenzie model, it's like you start talking to a physician, they may not understand what you're saying, or it may not relate over in your language. So you want to be able to shift gears and understand it from the person you're talking to, the medical professional you're talking to's world, but then also the world that we have to live in as far as a therapist and what we're treating. I know that I can work in the functional model, the structural model I do need to be aware of to say, okay, this person has this condition. Okay, now what is my role in treating them in that functional world?
Yeah. It's like the difference between an architect and an engineer. It's just like the doctor is the architect. They look at the structure of things, they look at how things are put together, and they say, okay, this thing is broken down and this thing needs sort of that medical intervention to fix it. And we look at it from a perspective of, well, we can shore these things up by doing these different things. Improving the motor control or improving the strength or any of these different, improving movement patterns, things of that sort of nature. So being able to relate those things to a physician, especially when we're talking about, and it gets into a lot of the political and insurance versions of these sort of things, where you're trying to convince a physician like we need 3 or 4 more sessions here, or we need to be able to do this after a surgical intervention, these sort of things. So being able to have that carryover, that crossover between our kind of lingo, I guess, as it comes down to it, is an important thing because we do have to be able to do that.
Yeah. Your classic signs, pain is often worth it. Long standing, bending. It could be lifting or it could even be sitting. because this segment is able to shift into a position where it's not going to tolerate prolonged positioning because of the tension that's being placed, at this expanded neutral zone, whether it's the facet joint, the disc, or some of the other inert structures. Classically we've been described as, it can be sudden, in severe cases, a sudden, unpredictable giving way, catching sensation, movement, you know, neurological signs. In severe cases, yeah, it can shift in a way where now all of a sudden you can have nerve recompression, which would give you radiculopathy. You certainly are going to have nociceptive or somatic pain with this, where you could be getting referred pain into the buttocks or upper leg, but not radiculopathy, which is neural compression with neurological symptoms. I think the most common thing I see would probably be that failed load transfer model, where it's more subtle. It's where if I have this instability and I have to go and lift to pick something up, if my back shifts and can't properly stabilize, then my shoulder is not going to be able to generate force, or my hip is going to inhibit turn off. The system then kind of fails on itself. It collapses, much like a unstable Jenga, as it were. So, many times with instability, it's not this clear. It's like, oh, they get this catching in their back. That's pretty clear. But it's more a matter of, okay, I go to push off a leg and I can't transfer that load through my lumbar spine. Then all of a sudden it's like my hip is going to shut off. Or if I go to, swing a kettlebell with my shoulder and I can't stabilize that lumbar segment, it's going to shut the system down. And I'm going to see something kind of come out of it. And Eric, you probably have plenty of examples of this load model from the lumbar spine.
I mean, I've always thought about it as like, if you have a weak chink in a chain, right? That's developed tension, right? So if you have something that's being held together by a piece of chainmail, and one of the links in that chain is not sufficient, right? All of a sudden there's more stress put on all the other structures that are around it, right? So if we're looking at it from a perspective of, say, it's a muscular instability that we're dealing with, where there's poor motor recruitment, something of that sort of nature, some inhibition, all of a sudden the passive restraints, the structural components like the disc, like the ligaments, like the facet joints and all those different things, they're going to suddenly absorb more load, right? And I think that's one of the major things that we're going to try and teach you guys, is to understand the difference between, kind of the traumatic mechanism of injury, where something just, you twist your knee and, the ACL gets too much pressure on it and pop, there it goes. That's a traumatic issue. But these kind of cumulative sum factors that come on in patients where they say, I have no idea, it just came out of nowhere. It's usually something where we have some issue where this tissue is consistently and repetitively absorbing more load than it's supposed to during some sort of daily or functional activity. And then all of a sudden it just starts to break down, right? So a lot of these things happen in various different ways, whether it's from, some sort of abrupt movement trying to lift something, or swinging a golf club, or it's something where it's real simple and you bend down to pick up a pencil and all of a sudden, bang, there it goes. So it's important to understand the idea of failed load transfer. There's a lot of different words for it. Forced overuse is another way we look at these sort of things, as far as terminology, but it's just a question of mark of, where did this stress come from? And that's really one of the things that we want to go and treat in the long run. Is we can go in and treat the painful structure all we want. We have, a swollen knee that can't move very well. We can go in and do mobilizations all day long and get that back to normal. But if we don't understand the reason why the knee started to break down in the first place, again, outside of the particular traumatic problems that we have, like a forced hyperextension or a forced valgus load that's coming from a leg length discrepancy, which is something we'll talk about for the next year and a half. Over time, if we can't figure out where that load comes from, we're not really fixing anything for this patient. We're just getting them out of an episode and sending them on their way, right? We want to try and minimize the amount of episodes that they have, or if we can, eliminate the amount of episodes that they have. But in order to do that, we have to understand where this load transfer is coming from, where this stuff is coming, where things are kind of breaking down.
Yeah, I guess a simple version of thinking that is, okay, you're doing hip, you're checking the hip abductors and the sideline. You press down on, on the thigh and the leg, and you cut through it pretty easily. It's like, okay, do I have weak hip abductors? So my glutes are weak. It's like, are they? The next thing I do when I have that is, if I stabilize the innominate and the SI joint, are those muscles now strong? If I stabilize the lumbar spine and with a deep contraction or there, is the leg now strong? So my strength test is my first signal that, okay, I need to keep looking. I don't stop my strength test with, hey, oh, this muscle's weak, they're weak, I need to strengthen it. It's my first thought is that, okay, where in the chain here do I get for the load transfer that may be being impaired? So stabilizing many times the SI joint there, all of a sudden it's 5 out of 5, but the muscle can't be weak 1 second and strong the next. I know that when it goes to transfer load somewhere into L5S1, the innominate, there's a disruption in this stabilizing system. And I want to find it. Saw one yesterday with hip extension in the glutes. Okay, having somebody do hip extension and you cut through them right away. I stabilize the sacrum and the innominate, and it's, I could almost get my full body weight on the back of his leg. It was just so by stabilizing the pelvis and not letting that weight, that transfer of load go into his lumbar spine, he was immediately strong. Whereas otherwise, he's probably 4 out of 5. I can cut through him, non-fatiguing weakness, but it was easy to cut through versus, holding me up on his leg. So when you test the muscle and find it weak, I want you to think of what are the peripheral things that have to stabilize to make this muscle strong.
Yeah, it's one of the more interesting concepts that we'll teach you guys is the idea of generating force output. And I think we're going to do an entire one of these sessions on it at some point, because there's just all kinds of reasons that muscles will pop up as being weak. But when we look at it, and I still do this, I still note on my documentation where I say, okay, the muscle's a 3+ out of 5, something like that. But really, realistically, I do that mostly for, outsiders, somebody else that might be looking at it, another PT, a physician, et cetera, that might need to have that kind of thought process. But I don't look at it from a grading perspective. I'm looking at it from why is this thing, like just like Dave was just talking about, where is this inhibition coming from, right? Is it coming from a local source, something in the joint that's around that joint that's affecting it? Is it coming from a regional independence thing, like Dave was talking about the SI joint being an issue where it's more of like a girdle problem that's causing these issues? Or are we looking at some sort of referenced problem from a lumbar segment, an instability, something of that nature? Is it fatigable? Is it going to be looking more like a neurological component? The way we do our muscle testing can actually tell us a lot about that sort of stuff. And so we'll get into that a lot more as we go along. But I'll tell you this, that it is one of the greatest parlor tricks that we can do as a PT. I mean, like I always tell patients when I'm doing these things, retesting muscles after doing something to correct one of their problems and showing them how strong it becomes just instantly in the clinic. It's one of the best things you can have for buy-in in the clinic with a patient. They'll look at that and be like, how the hell did you just do that? And it's really good for that patient therapist interaction. But it also just tells you that you're working on the right stuff, which is kind of what we're hoping for anyway. We want that objective evidence that we're going in the right direction, right? So, and that's one of those things that we can do.
Yes, we'll chat about that in the courses too. It's because you want to build rapport with the patient and get buy-in. And when you do that and make them, they're weak and then you make them strong, they're going to have confidence in you and get buy-in, and you're going to kind of start to build that relationship. Then I'm like, okay, like, oh, this is a really good sign. If we can do this, this speaks well. And then, now you're giving them hope, which is really why they came to see you.
Yeah.
To kind of have hope.
It kind of sometimes challenges the idea of, we need to do strengthening with patients as well, right? So if a patient comes in and they've got an ankle issue, and I do a couple of tests and I say, okay, yeah, it looks like this is a local problem at the ankle. It's affecting all the muscles that cross the ankle. So I'm looking at this saying like, okay, I have a local issue here, and I show them how weak it is. I do the technique or the treatment that I need to do, retest it, and it's like, oh, magically this thing is as strong as can be. Does that patient really need me to send them home with, a TheraBand to do, 3-4 sets of 10 of, 4-way ankle strengthening? If I just prove that the muscles are strong enough when things are functioning correctly, right? At that point, you have to start thinking about the process of how do I prevent that problem from reoccurring? And that's more of my, what I would call the rehab component is re-educating those movement patterns, helping patients learn how to stabilize things, getting that kind of nervous system to, it's not just the nervous system because we have to look at joint receptors and all these different things that play a role. But how do we get those things to function the way we need them to? Because it's not a strength problem, right? We're not looking for hypertrophy of some of these muscles when we're treating these things, because it's there. The strength is there. It's just being inhibited by some of these other problems.
Again, manipulation, of course, let's put it in your, subluxation model and instability. A joint subluxation where it gets stuck at an end range motion, you can assume that you have some type of instability or expanded neutral zone of the joint because the joint has been able to get stuck. So there'll be some type of instability. They just happen to be in a fixed state. So with this subluxation, it's going to change again the neural recruitment patterns around it, whether it's a guarding or a splinting of that area, or moving more through another area. So the subluxation, doing that and releasing that will allow for the normal motion and remove that barrier. So let's say, hey, I go in there and I do my neurophys technique and I correct them. They're perked up, but if I miss that, okay, this person has an L5 S1 subluxation or TL junction restriction, then they're probably going to knock back up within the next few hours. And it'll regress back to the familiar. So they'll come back in and look the same. So when we look at something that may not be moving biomechanically to its optimal level, then there'll be a regression. So by being able to manipulate the lumbar spine or TL junction or hip or ankle, the idea is once you restore that mobility, then you can start to re-educate the movement pattern and retrain the pattern and work on the feed forward mechanism. But this can be a really big barrier in getting this person to progress if we don't address that limitation restriction or completely understand it as maybe it's a hypermobility or called a ligamentous instability, like a ligamentous tear, and now they're having a really hard time controlling it. Then our strategies need to change, whether it's a subluxation in a joint that can't move because it's temporarily stuck, to a hypermobility.
And this will be one of those things you guys see in clinic that's frustrating to you, right? Because Dave talks about you do your technique, things get moving better, everybody's feeling pretty good, and then a handful of hours later, maybe even a couple of days later, maybe a week later, they come back and they're exactly the same as they were, and you're sitting there ripping your hair out because you can't understand why things won't stay together. Believe me, it still happens to me. When patients will come in and you treat them and they come back and things just don't look like they've changed much. And at that point, there's usually two things that I will tend to look for. The first one is this instability, right? The idea that this segment is itself unstable. And the reason when I manipulate it, it won't stay put is because it's not physically able to control where it is in that neutral zone, and it just ends up sliding off the rails into that spot again. The body will get used to developing stability however it can, right? And so sometimes the body will fixate things to generate some sort of stability, but it's not an appropriate stability. And in fact, it's affecting other parts of the neuromuscular coordination mechanism, right? So being able to train that and maintain a more normalized neutral zone is an important thing, right? The second thing is maybe there's some other issue that keeps driving this into that position to begin with. And I'm talking about some other distal issue in another associated body region. Probably the one that we see the most, and I bet Dave would agree with me on this, is the instability in the lumbar spine that starts jamming up. That's actually being caused by a restriction somewhere in the thorax, right? That's kind of pushing this thing into that particular direction because it has to, right? If I can't move through the thorax here, and we talked about the lumbar spine not being a rotary structure, not being a rotary region, if I can't rotate through the thorax, or rotate my trunk anyway through the thorax, the body's going to try and do it somewhere, right? It's going to try and maintain that available range of motion. And so I keep kind of pushing some of these lumbar segments into these positions where they jam up, or they at least are banging against these end range structures, producing pain. Right. So these things are kind of the two most common issues that I think I see when I have that frustrating patient that comes in, I fix them, they come back and they're the exact same, right? Either there's some sort of structural instability located within that body region that I'm treating, or there's some sort of biomechanically associated region that's not doing what it's supposed to, that's continually forcing it into that position. But I'm guessing you probably see that all the time too, Dave, right?
Oh yeah, absolutely. Actually, Carolia wanted to talk about like all the things in the lower extremity. Let's say I have an L5, right-sided extension subluxation. Someone would drive it Carolina knows all about the things that would drive that into extension. So she'd like to tell you about the hip and the ankle and how they would do it, or the innominate. Don't you?
Oh, of course. I would love to. So I mean, if it's gonna be like an L5 right extension subluxation, so it's stuck in extension, so we might see that the innominate is stuck in like anteriorly. And then from there, they might have difficulty going into that swing phase forward. So we might see like a longer leg while landing.
Yeah. Give it a little more general. They're still a little new. What would happen at the hip? What would drive forces up in the L5 into extension at the hip?
Like a long leg could, like, let's
Long
say if
leg.
they're, pardon me?
Mhm. Yes.
Yeah, like if they have a longer leg, let's say on that left side, that can drive that lumbar L5 right into that extension.
Yeah. What about the hip? Would the hip be lacking a certain motion that could also do this?
Mhm. It might be lacking flexion.
Action?
Well, if it's stuck in well, I guess if it's stuck in extension, it can't extend anymore.
Yeah. If the hip can't extend properly at the end range of gait, we're going to make it up in the lumbar spine. So if
True.
I get to late phase stance, my hip can no longer, I've lost extension because I get a capsular pattern of restriction. It's going to drive L5 up and create an extension subluxation.
And that's where that anterior innominate rotation you're talking about would come from.
Yep. Or drive the anterior innominate there as well.
Twist that forward to try and make up for that loss of hip extension. It's important to note, though, when she's talking about the leg length issue, we're talking about a functional leg length issue, right? So
Mhm.
this isn't something that's a structural problem. That, the leg is not 2 inches shorter, from a structural perspective. It's operating longer, meaning that there's more length during the stride that the person is developing on one side than there is on the opposite side. And so we have to kind of try and take the body, because of gravity pushing us down and the ground reaction forces pushing us up. There's this compression that occurs to us. But if all of a sudden on one side we have something that's pushing us up higher, like a loss of hip extension, then all of a sudden the leg is functioning longer on that side. And that's where these two opposing forces, the gravity coming down and the ground reaction coming from above, coming from below, they start to compress between us, and then the lumbar spine has to hyperextend in order to kind of create that give, so that we can kind of even out our stride. So it's not something that we're dealing with as far as an architectural problem, where all of a sudden, one leg has become, 2-3 inches shorter than the other, which we see a lot of people doing, putting things in shoes to even out stride lengths and things of that nature. That's kind of, we can talk more about that when we get to the peripheral course and whatnot, but that's not always the best option to do.
Yeah. And you take this down the ankle, this could be somebody can't kind of dorsiflex the ankle. There's restriction there. And that alone there can also drive forces up, into the pelvis and lumbar spine. So this can come a long way. And now we've gone from where I have somebody who can have an L5 extension subluxation that I'm going to manipulate, but it's going to easily be somebody with a hypermobility or an instability into extension in the lumbar spine. It's not subluxed, but now all of a sudden the neuromotor patterns are off. The recruitment pattern, the cortical drive, those things are off. But the primary driver of this was somewhat peripheral. And that's what we're going to spend a lot of time just kind of also working on as well, is being able to identify this. Okay, I have this L5 S1 problem. Okay, what are the potential causes of this that are outside the L5 S1 region? Looking for, very common ones, and then also looking for more remote outliers of these instabilities. So that's where it gets fun looking for instabilities, is looking at these other things. Clinical tests to think about. We have active movement testing, for altered lumbar pelvic mechanics. Well, this will be put in the back end of this, or we'll be doing in future modules, looking at, many people have talked about different flexion and extension models and how we look at active motion. We will look at active motion during the course and talk about that a little bit, about aberrant motions that we will see in range of motion of bending forward. Who has a flexion instability model, it's been described by multiple people, Diane Lee, we have Shirley Sauerman, Peter O'Sullivan kind of come to mind as three that have described these different flexion extension pattern models. It's different than the McKenzie model that you think of when we talk about it or there. So it's a little different. You have to look at them slightly separate, but we will look at that in the range of motion. What is aberrant about what they're doing, which may be stressing the segment? You know, when I'm bending forward, what initiates it? Is this person bending through their lumbar spine with a posterior pelvic tilt? Or are they hinging at the hips and initiating the motion properly through the hips and an anterior pelvic tilt? You know, those become really important in these patients with these types of instabilities. That is their habitual movement pattern driving this instability? Because that's low-hanging fruit. That's stuff you, once you see it, as I was talking about it this yesterday, is once I see that they have a flexion, dysfunction that way, it's great because I'm 5, 6 minutes into my eval and I know what I'm doing for the next 45 minutes. That's low-hanging fruit. I need to work through that first. And they're going to think I'm a rock star because I can change the way they move and change their pain pretty quickly. So I'm hoping they have that because I like to look smarter than I am. Eric will attest to that.
Tough to do sometimes for you, Dave, but
Yeah, it is. It's a struggle.
it is a goal. It is a goal.
Other people describe other things, passive lumbar extension test. That's that stability test that we talked about, okay, can they stabilize it? And many times you'll talk about doing it with the active system. Okay, if I overpress on the back, can they extend? Looking at some of the segmental stability tests and the prone instability test as it's been described. Like those are kind of good ways of showing, do I have the muscle, stabilization to stabilize the joint? If I change it with manual overpressure or improved muscle contraction, can I change the pain in the aberrant pattern? And again, here we kind of get into a bit of some of the patterns, the contributing things, movement pattern dysfunctions. We'll go into this a little bit more detail. There is that, you can have somebody who has a hinge pattern of flexion through the lumbar spine. That's typically going to look like somebody when they go to bend forward, they're going to go through L5S1, but more commonly probably L5, L4, with excessive motion at that segment as they bend forward. But then also on their return from flexion, they're going to lever through it. And I like to think about this is that, the facet joint's maybe the size of my index finger now. The hip is the size of roughly my fist, a little smaller, but about the size of my fist. I want to kind of lever when I'm coming back at flexion through my hip, through my glutes, not through the joint that's the size of my index finger. Because the amount of torque created there is tremendous. So when somebody has one of these movement patterns where they're hinging through that lumbar segment versus initiating with the hips or thorax, it creates a tremendous amount of load on those segments and breaks them down. So we want to be very, very careful when we're looking at the range of motion. If you have their shirt down, you're never going to see it. You need to be able to see the skin in the lumbar spine. So I can't do range of motion testing on somebody, without seeing what's going on in the back. If they have a shirt on, then, I can assess their general range of motion, but it tells me probably very little about what may be happening in the back, and I'll miss it. Extension patterns we'll get into as well as lateral bending and rotation patterns. Degenerative changes, certainly loss of disc height, set joint arthritis, ligamentous laxity. These are all things that naturally occur, and they lead to that stage 1, stage 2, instability that Cicaldi and Willis talks about. Traumatic fractures, ligamentous injuries, these are all things that would do it. So now we're in the medical model of, okay, what are the things that would create these, structural instabilities, muscle dysfunction. That's that functional instability model that we like to talk about in the world where we tend to live in. And postural dysfunctions leading to altered load distributions. Now, again, we're all taught differently, and we've been told some of you along the way that, hey, posture doesn't matter, posture is inconsistent, can't count on posture, it's not posture. And it's true sometimes, but not every time. And that's why with us is like, much as we get clips here and there of what's important and what we should do, there aren't hard rules to this. Sometimes posture doesn't matter so much. Other times it's everything. And lots of times it's somewhere in between.
Yeah,
But
I'll say I'm generally not so concerned with the position that a person starts in. I'm more concerned, can they get into and out of the various motions that they need to be able to get into and out of, right? So I'm more concerned with movement than I am with posture, but especially when we get into the thoracic components, posture is going to become a very big thing because it's not so much just their resting posture, it's a sustained position that they put themselves into for hours a day. I mean, if I sit here at this computer for 8 hours today, the position that I'm in for that 8 hours is going to become a very a big part of what my body is physically capable of doing, especially if I have, kind of the, wishes of getting up after doing this and going for a run, or going to lift weights in the gym, or going to play softball, or going to the driving range. It's that dynamic, that duality of thought processes here, where we're static, not moving, we're in a particular position or posture for multiple hours a day, and then all of a sudden we're going to start demanding these kind of dynamic movements to occur in a totally different position or posture. That's where I think posture becomes something that we have to take into consideration, because it can be a perpetuating factor to a lot of the problems that we'll try and deal with, especially, like I said, when we get into the thoracic region.
Yeah, pathophysiology. I put this in here. It's just a nice summary because you're gonna have in here again the Ricaldi and Willis kind of summation of dysfunction, the three phases that they talked about, which you're gonna see them kind of pop up here and there as you're reading or you're looking at articles. Like, okay, yeah, I see these guys. There are references everywhere. So it's a good one to know. It's a good one generally in your mind. So I joke with my patients who are in the instability phase somewhere in their 50s. I'm like, listen, if you can just kind of you're going to ride this out. But, again, eventually once you get old enough, you're probably not going to have this pain much anymore because you're going to reach the phase 3 where you're going to get stabilization and osteophyte formation. So as long as you don't compress a nerve, you may have less pain. That's generally the reason why people can have very degenerative spines, but not have tremendous amount of pain. It's almost like a self-fusing process. So, as long as you're not getting, neural compression or irritation of the door or inflammation of the disc structures, the stabilization phase isn't the end of the world.
No.
Yeah.
It will tend to suggest that there's very likely some neurophysiological mechanisms that are going to be permanent at
Yes.
that stage, because we can't, I mean, I guess you can to some extent regain motion once you get into some of these, the phase 3 components. It depends on if it's scar tissue, connective tissue stuff and things of that sort of nature versus osteophyte formation and fusion of segments. But whatever neurophysiological components that will start to become dysfunctional during phase 2, which happens a lot, and we'll talk about things like segmental facilitation and whatnot as we go along here. Those things will start to become more permanent once we reach the stabilization phase, because they're going to constantly be in that sort of scenario, right? And there's no way for us to get them out of it at that point.
Yeah. And it's just knowing the lay of the land. This is a 75-year-old male who's lacking spinal extension. I'm going to know that there's probably a lot of segments where he's in this stabilization phase. Does he have, lateral stenosis or central stenosis? Potentially. But I know that, okay, with that in there, it's either going to be kind of a hard capsular end feel or that arthrosis end feel in the joint that we're going to have. And we're going to probably talk about that, I believe, next session, about different types of end feels that we will encounter within this. That's kind of where there's a lot of value determining, okay, what's this end feel? Because the instability phase, that's going to be probably the phase 1, phase 2 will be your manipulable lesions. Once you get to this stabilized phase, and you're going to really see this probably most prominent in the cervical spine, where it's like, okay, this joint is arthrosed versus a joint that is, jammed and subluxed. Terminate. And that's that differentiation. Your manipulable ones, phase 1, phase 2. Once you get to phase 3, those are the joints that are kind of permanently fused or very low of a hard capsular end feel at that point. Just jump somewhere there. Good. Boom. Again, imaging, just kind of throw it in there. You can kind of see just the different things with imaging. Ultrasound's an interesting thing in our world because it's becoming more prevalent, and looking at multifidi activation timing and hypertrophy. So ultrasound is just a little interesting one that's out there kind of in our world. The other ones you can kind of assume that we're going to see these structural abnormalities associated with these dysfunctions. Conservative management, I'm going to flesh this out a little bit more, but conservative management versus the motion state of the joint. I would say, we're core stabilization. What I would put as number 1 would be, I want to understand the lay of the land. If we're talking lumbar spine, I want to know, okay, what's my segmental mobility? My age will dictate a lot of what my expectation is. If this is a 22-year-old male, I don't expect, arthrosis and, fused joints and lack of extension due to osteophytes. I'm expecting, okay, maybe I have a disc or muscle guarding. I should have a relatively good neutral zone, unless he's been doing something to impair it. So the motion state of the lumbar spine is where I want to go first for this. The core stabilization exercises, they're always going to be, part of the phase of what we're going to look at, but understanding what this joint is doing and does it lack, if I get to like an L4, L5 and I do a rotation stability test and this joint's able to rotate, that's a problem. And I need to account for that. Sorry, look at some of the questions here. We'll come to them. Just let me go through number one, then we'll hit the questions. Manual therapy is in there, like, core stabilization is important, but especially the manual therapy, I would say the assessment's key first. Like, what am I going to do? Be dictated by what I found in this. Is this mobilization for proprioceptive or facilitatory input to the multifidi? Is it manipulation to address an articular restriction that I'm doing? Movement pattern retraining. What is the faulty movement pattern that is allowing stress to accumulate at the segment or me to move through the segment in an aberrant pattern? So, retraining the neuromotor patterns we're doing. Certainly educating the patient on positions of ease, really, when we think about posture mechanics. What position can I put this segment into that's a neutral position of ease that doesn't stress it at its end zone? If I have a flexion dysfunction and I'm sitting in a slouch posture all day, it's not going to help things. I want the joint to be in its neutral, optimal position because that builds capacity later. Like Eric was talking about, I mean, how many times have you seen cyclists, Eric, who have desk jobs, and then they get up and they go want to ride hard for 2 hours in a flex position. So they've got this hysteresis and this stretching out of the posterior elements, and then they go out and try and lever through it with force, and it breaks down. So when I'm seeing athletes, one of the key things I do is say, like, what you do during the day matters. Like your rest positions during the day set up how you're going to feel if you're going to go run afterward or ride bikes or play lacrosse. You have to look at your optimal positioning around your sport so it's setting up so you're not suffering from this low burn of hysteresis and stretching of this ligamentous and disc structures as we get into it.
And it becomes more important the older you get, unfortunately.
Yeah. I say that with a great deal of reservation and acknowledgement.
Yeah.
That and warming up, I admit it. I didn't need to warm up so much when I was younger. It was more of a free throwing thing. Now it's like, boy, I try and work out coming out of bed. It's like, holy cow, who hit me with a bat?
Yeah. That's definitely a thing. For those of you that are still younger, enjoy it while you can.
Okay. Got a question here about urinary incontinence and instability as well. Have you seen both? Absolutely. You're going to see that it's a load transfer issue often, through the pelvis. So there we're getting into pelvic floor TA activation, timing, and pattern. And there's multiple reasons why you'll see that there. Some of the mechanical regions can be drivers of that urinary stress incontinence. We're seeing it. And, Eric and I can be talking about like this can be coming from the hip or the foot, where you have an instability at the hip that failed load transfer is then reflected in the pelvis, and that creates incontinence. You can also see that in the thoracic spine, where if they have a thoracic ring shift or subluxation, it's going to change the firing pattern of the abdominals and the obliques and pelvic floor. So you'll see that, okay, I need to maybe address what's going on in the thoracic spine to address if let's say it's a stress incontinence in a female who's doing box jumps and she gets a stress incontinence or a runner.
Yeah,
those things need to be addressed.
That's probably one of the major ones that I'll see is the thoracic one. And it's usually either via the obliques or some of those long thoracic paraspinals, the iliacostalis, et cetera, where it'll affect position of the pelvis relative to, the sacrum, et cetera. And so this will affect kind of the length tension relationships that you get via the pelvic floor. So are we able to kind of anchor through the pelvic floor appropriately? And then when you start to put that stress on it, all of a sudden it just kind of starts going, right? But there are some mechanical factors that are at work there that we can correct or at least work with. There's a lot of times where I've seen patients that'll have these sort of things, and I can do the hands-on stuff. I can say, okay, I can search out and find where I think these dysfunctions are coming from, and I'm probably more qualified to fix it. But there does become a certain perspective at times especially with females, where it's just like, I don't do pelvic floor stuff very consistently just more from a medical legal perspective than anything else. And I'll Be happy to tell you guys the story about the Diane Lee course that I went to at one point that was like 48 women and 4 guys, and I was the only one there that didn't do intrapelvic techniques. I was kind of debating whether or not I should just fly home. I haven't been going to that one, but it's one of those things that it's definitely possible to have that.
Yeah, I mean, I work with a pelvic floor therapist now and utilize them. We'll go over superficial palpation screening. That's what I'll do is, we look at TA, we'll be able to palpate pelvic floor activation pattern. And you may not be able to clearly say, oh, it's hypertonic or hypotonic, but you'll be able to detect, this is off. One thing is not like the other. Okay, maybe I find you're a big enough network of therapists. We're going to find a pelvic floor therapist to say, hey, maybe you take a little closer look at this and say, is this hypertonicity versus hypotonicity? Is it a timing issue? Is it not an issue at all? So that becomes a player. If they have incontinence, it's an issue. You want to get it sorted. By the time we finish, hopefully what you can do is you can kind of start to play with, oh, look, I mean, maybe I found the hip is not stabilizing when she's in single leg load. If I fix the hip, does it stabilize the pelvic floor? It could be a hip driven incontinence or pelvic floor, or it could be a pelvic floor driven hip. And you'll be able to play those two things off of each other and see which gives you the best result. And by the time we're done, you'll be able to say, is this a foot driven pelvic floor? Hopefully we didn't go into too much depth. The risk with this is we start talking about peripheral things and we don't want your eyes to cross and get too lost, but we do want to give you a vision of kind of where we're going and why we want this solid foundation here so that when we're in the labs, we can focus on lab skills and hands and structure. So this is really important as a concept to understand this, because this will be a uniform theory throughout what we're doing. And that's what we're kind of going to cover in these modules as we do it. So your questions on the board are great. Keep asking them. Beyond that, that was just about right.
Yeah. Any other questions that we can answer without